coming on this cold, rainy morning. Are you guys, can I just kind of see a raise of hand? Who's interested in hearing about osteoporosis and who's interested in hearing about osteoporosis? Okay, one hand. Oh, okay, 4 hands. Who's here about gout? Okay, it's pretty evenly split. This talk is actually usually about an hour long for each of the topics. I've been given 15 minutes for each of them, so I'm going to kind of fly through the slides and kind of maybe highlight some of the points that I think might be more important for you guys. We'll start with the osteoporosis and then go from there. Okay. So osteoporosis, just to tell people what it is, it's a condition where your bones are more fragile than would be expected. There's a reduced bone mass, and there's a change in the architecture that causes it to be more fragile and more likely to break. You can see the normal bone that has that's dense and thick and has connectivity to each other, as opposed to the osteoporosis bone that loses that connectivity, and that's what makes it actually more likely to break. There are many people who have osteoporosis. 6 million postmenopausal women currently have osteoporosis, and and even more than that, 13 to 70% have something called osteopenia at the hip area. We reach our peak bone density around the age of 30 or so, and after that, unfortunately, it's all downhill. So we'd like to make everything, if we can kind of improve that peak when we're younger by improving the diet of our young people and making sure that they do all the good, healthy lifestyles as well as exercise, it would be helpful. Prevent them from smoking, and exercising, weight-bearing exercise would be great. This is the impact of osteoporosis. This is a picture that we often show that in a young person who have a nice, good posture, as they get osteoporosis, they get compression fractures. There's a curvature, and it's not only pain that comes from osteoporosis fractures. There are health problems with this, as the lungs kind of get compressed. There are sometimes, breathing sometimes can be somewhat of a problem. Posture can be a problem, and it's hard for them to sometimes look forward when their back is curved over, and they're at increased risk of falling. If we look at the fracture incidence, this is something that's more common than cancer and heart disease. 50% of Caucasian women over the age of 50 will experience osteoporosis sometime in their lifetime, and 25% of men. And as we live longer and longer lifetimes, which is a good thing, we will see this more and more. So it's really important that we do something about this, given that this is a disease that's preventable. In the U.S., it was estimated, this is actually about 10 years, there's 250,000 hip fractures in that year. And hip fractures are associated with significant amount of morbidity and mortality. Some people, 10 to 20% of patients will die within the first year of hip fracture. Less than 10% of those patients will actually end up being able to function to the degree of functioning that they had prior to the hip fractures. So there's significant problems associated with this in both cost and suffering for the patient. Hospital costs are significant for hip fractures because you have to be hospitalized, you usually have to have some kind of surgery. And in 1995, the fracture treatment cost the healthcare system in the US alone $8.68 billion, and it's only rising. There are significant risk factors that we can do some things about, and there's some things that we can't do anything about. If you're a woman, as you get older, if you're a Caucasian person or Asian person, your risk of fracture is higher than a Hispanic individual or an African American individual. If you have premature menopause by surgery or because of other reasons, if you've had prior fractures or if you have a mother or father who have had hip fractures, that significantly increases your fracture risk more than some of the other factors here. Having inflammatory arthritis, the rheumatoid arthritis, inflammatory bowel disease, ankylosing spondylitis, psoriatic arthritis are all contributing factors. Other endocrine problems, hormone problems, like having too much thyroid replacement or too much thyroid function, malabsorption problems. If you have celiac sprue, colitis, bypass, these are all contributing factors for developing osteoporosis. There are things that we can do when you're younger if you can achieve better peak bone mass by making sure that you have good calcium intake, not being vitamin D deficient, which is actually a big problem for us right now. not smoking, limiting alcohol intake, exercising, making sure that if you have low testosterone maybe or hormone problems, that you replace that. There are significant medicines that we use that severely contribute to this, like steroids. It's also called cortisone, heparin, seizure medications, stomach acid reducer medications called proton pump inhibitors, and some patients who have prostate cancers or breast cancers are being given certain hormone therapies, and they are contributing to osteoporosis development as well. We diagnose osteoporosis based on many different things. If you've had a compression fracture of the back without really doing much anything at all, that is actually osteoporosis. You don't really need a bone density to tell you that you have osteoporosis. If we look for, in a physical exam, we look for all the history and other modifiable risk factors. We look for exam changes that suggest that person's had some osteoporosis and compression fractures. We have blood tests to look for diseases and medications that contribute to osteoporosis, like checking their thyroid, checking their blood calcium level, etc. And then we do something called the bone density test. How many in this room would have had a bone density test before? So you guys kind of know what that's like. So we have certain criteria as to who should be tested. We think every woman who's over the age of 60, 65 should be getting tested for a bone density test. And if you have risk factors, that you should get considered with testing. Men over the age of 70, and also if you have risk factors that we had just talked about, you should consider getting tested. And if you have fragility fractures, you should consider getting tested. And if you're taking steroids, even if you're a young patient below the age of 50, I will actually check the bone density test to make sure that we're not having a significant loss. And if somebody's taking more than 7.5 milligrams of prednisone a day, it is recommended to take some medication to actually halt the progression of bone loss. This is what a DEXA machine looks like. You're just laying on a table. There's no poking, no prodding. You just got to lay on a padded table, and this device kind of goes over you where they're actually measuring the amount of calcium that they're able to detect. It is right now the most important predictor of fracture risk, so it is something that we do want people to get to follow. Usually there's like a peak bone mass, and as you get older, there's a loss of bone mass. And the T-score is what you would be at the peak of your youth at age 30 or so. And that's how we define osteoporosis. If your T-score is one of the numbers that you'll see on a bone density printout is above minus 1.0, then that is normal. Between -1 and -2.5, you have osteopenia, which means that you're kind of in the middle. And if you're at -2.5 or lower, you're defined as having osteoporosis. We also have blood tests that measure what they call bone turnover markers, but they're not really used for diagnosis, and it's not something that we do all the time. But we can use it to sometimes monitor drug effectiveness. Now, people have always asked, what is the right drug for me? What do I do? Well, it depends on, who you are, what your problem is, what we think is going on, how bad your problem is based on bone density, your history, what medicines you take. And then we kind of look at this and kind of come up with a formula and say, this is what we think that we should consider doing. There are a lot of people who was started on medications probably about 10, 15 years ago when they were told that they have osteopenia. And they would come see me, and I would say, well, your fracture risk is not that high, so we probably shouldn't give you medicines. And people would say, well, how did you figure that? And before, I had read a lot of articles, and I had some gist of how we should be treating people, but we didn't really have a way to tell people this is the reason why. And John Canis from University of Sheffield came up with this formula, and it's called FRAX, F-R-A-X. And you can Google this, and this actually will pop up. And then you choose what country you're from and what race you're at, and then they give you this little questionnaire, and then you answer the questionnaire, and underneath this, they tell you how to answer the questions. Because sometimes you say, well, what do you mean? How much, do I currently smoke? What do you mean, do I have a previous fracture? So they have definition of what each of these questions are below that. And even if you don't have a bone density, the DEXA result, they will give you some estimation of your fracture risk. If you have a DEXA report result, then you can select the type of machine you have, put the bone density result of your hip, what they call the femoral neck, not this neck, but the neck of your hip bone, and they'll give you an assessment of your fracture risk for the next 10 years. One of the numbers they give you is something called, it's a risk factor for fracture in the next 10 years, and another number is a risk factor for hip fracture in the next 10 years. And because of this, now I can give people a number and say, this is a reason why you should be on medicines, or this is a reason why I don't think you need medicines yet. The older you get, the risk factor increases quite a bit. This is actually a slide that I borrowed from Dr. Shibuya, which I really love because it has these ABCs on a mnemonic that makes it easy to remember things. So he called it the ABCs for prevention of osteoporosis, and I think it's really great. And for A is to achieve your peak bone mass. When you're younger, try to do whatever you can lifestyle-wise to try to improve this. I have patients who come see me about osteoporosis, and I tell them, some of the things I'm telling you is really not for you. It's for you to pass on to your children so that they don't have these problems when they're your age. So, not smoking, again, minimizing their alcohol intake, exercising regularly, getting enough calcium, and checking their vitamin D and making sure that's adequate, I think are very important things to do. Weight-bearing exercises are very important. It's not going to reverse osteoporosis, but it can improve balance. It can improve actually your muscle strength. It can improve your bone strength. So it is important to kind of exercise on a regular basis. I do tell people to do about 30 minutes a day minimum, and that's every day. If it's raining, get yourself a treadmill, walk in place. I do want people to be weight bearing. But if you're doing a lot of activities like gardening and household activities, that's actually part of that as well. But we do want to make sure that you're doing something weight bearing. Calcium intake, we'll talk about that a little bit more. We do recommend that people get about 1,200 a day. In divided doses, your body cannot absorb more than 500 or 600 milligrams at one time. So it is important you take some with breakfast, some with lunch, some with dinner. It's not good to take all at one time thinking that you're getting it all in. And vitamin D, there's an organization called Institute of Medicine who has recommended that most people need about 400 to 1,000 a day. Most of my patients, I recommend 800 to 1,000, and some people may need more. Some people ask me, doctor, how much do I need? I'm like, well, it depends on what your level is for what you take. So I will check their level, and if what they're taking is not adequate, sometimes I may adjust it up or down depending on what's going on. And again, E for end bad habits, stop smoking, limit alcohol, exercise, get off your bottom and start moving. And F, this is probably the most important thing. When we talk about osteoporosis, people are talking about bone densities, but it's really, what we're trying to do ultimately is trying to prevent fracture. And how do we get fractures? Well, if you have low bone density, you're at increased risk of fracture. But it also comes from some, usually injury, minor injury, falling, tripping, doing something. So I tell people, be careful of what you're doing. Take your time. Almost all the patients who have had fractures of their hips or their bones recently, it's always been, oh, I was in a hurry, I was running out the door and this happened, or I knew I shouldn't have been doing it, but I was, and it's like no more buts. Just say, I'm going to take my time because it's important. I'm going to be careful. I'm going to wear shoes that are sensible, wide heels, something that has traction in it. If it's raining outside, I'm going to take my time walking and watch where I'm going. And Tai Chi and other exercises that teach balance really can also help reduce risk of falls. And if you reduce your risk of falls, hopefully you can prevent fractures, which is ultimately our goal of trying to treat osteoporosis. And again, this is just a reiteration of that fact that you reach a peak bone density around the age of 30. Most men just have a steady decline. Women at the time of menopause, there's a little bit more rapid decline, but there's a continued decline after that. So once you get to 30, there's not much we can do, but we can do whatever we can to kind of stabilize it so it doesn't decline any faster. We used to tell people you have to get 1,200 to 1,500 milligrams of calcium per day, but that was primarily based on studies that had patients who were vitamin D deficient. Recent studies show that if you have vitamin D that's more replete, you may need only 800 to 1,200. So making sure that you have vitamin D adequate levels is actually quite important, not only for osteoporosis, but other autoimmune disease reasons as well. The best way to get calcium is diet. I cannot emphasize this enough. Diet, diet, and diet. And if you're worried about how do I know how much I'm getting, if you look at the foods like milk or yogurt, they always give you calcium content in percentages. So take that percentage, multiply by 10, and gives you the milligrams. So 25% in a yogurt container, 250 milligrams. For 40% in a milk, 400 milligrams. It's really easy to calculate. So if you can get a little bit of milk with breakfast, a little yogurt with lunch, some cheese at dinner, you may be getting all you need, and you may not need any supplements per se. If you're interested in calcium supplements because you're allergic to milk, you can't drink almond milk, you can't drink anything or eat any greens, God help you if you can't, but if you Google calcium content in food, there are lots of charts online that you can find that gives you calcium content based on the amount that you're eating for that product. But there are some variations in this, so you do have to look at it. If you're drinking milk, buttermilk, and other things, I do ask people to kind of shake things before you pour it out because calcium sometimes does settle to the bottom. There are calcium supplements, and there's been some concerns about calcium supplementation with heart disease. There was a study from New Zealand in 2010 that suggested that patients who take calcium supplements on its own without other things may be at increased risk of heart disease. Because of that, there's been some concerns. There are arguments going back and forth, but again, I think diet is best. If you have to take calcium supplements, I do recommend that you try calcium citrate. It's a little bit more dissolvable. And you have to actually read the label carefully. I've had people say, I'm taking 630 milligrams. And I said, bring the bottle to me. And I look at the label, it says, one serving is 2 pills. And one serving gives you 630. So if you're only taking 1 pill, you're only getting half of that. So when you read the labels, please read the serving size as well as the content, not just the content itself. And if you're taking acid reducers like Prilosec, Zantac, Pepcid, the calcium carbonate may not be as well absorbed. So I, again, recommend calcium citrate for most people. People who can't swallow these things, calcium citrate can be dissolved in water. So if you put it in like a glass of water and you wait for a couple minutes, it can actually make a slurry of it and drink it. So you don't have to worry about swallowing this big giant pill. With calcium carbonate, with vitamin D, and in multivitamins, there's no studies to show that that increases heart disease risk. So I don't have any particular arguments with that. Too much calcium is not good for you. Your body has to pee it out. If you take too much in, you can get kidney stones and other problems. So it is important that you not take too much. It is really the right amount that we want you to take. So I have people kind of figure out how much they're taking during the day through their diet, and whatever you're not getting enough, you can supplement in the evening with their meals. Or yes?
I'm just curious on babies or children like breathe. Do they have a limitation as well on calcium intake?
Usually, like for pregnant women, we have people take up to 1,400 milligrams a day. Children, they actually, if you're drinking 3 glasses of milk a day, they're probably getting enough. They have a higher bone calcium requirement because they're younger. So I don't actually limit the kids, but adults I do. But usually the kids are not taking pills, they're taking dietary calcium. So I have less problems with it. I'm sorry. And the vitamin D, it's usually a vitamin that we make in the sun, in the skin and the sun. Unfortunately, we do worry about skin cancer risk, so we are limiting that. If you're using SPF even 15, there's a significant blockage of the UVB rays. So you may not be getting as much vitamin D as you think if you're using, my base lotion has 15, SPF of 15 already, so I'm probably not getting a whole lot of sun. Vitamin D level in the blood used to be 20 to 100 was considered normal, but they found that when your levels are at below 32, your body mobilizes something called parathyroid hormone that takes bone out of your calcium out of your bones. So we do recommend your vitamin D level be somewhere between 32 to 100. Some labs have it at 30 to 100. I usually recommend my patients stay somewhere between 40 to 80. Too little is not good, too high is not good either. This is a fat soluble vitamin. And there's not that many foods that have vitamin D in it, including, they're primarily the animal proteins like fish, liver, egg yolks, and the only source of vitamin D you can get from vegetables is really mushrooms, which is not really a vegetable if you think about it. It's a fungus. But if you do fortified milk, there's only about 100 international units per cup, and that has, again, in surveys has not been consistent. So I don't actually have people rely on the dairy foods to get your vitamin D. I think you should be getting probably from fish sources, sun sources, mushrooms, or supplementation. This is really the only vitamin that I have people supplement on a regular basis. Who should be treated? If you've had prior fractures, you ought to be fragility fractures, you ought to be treated. Compression fractures, prior hip fractures, you should be treated. If you have a bone density test and it tells you that you have T-score of less than or equal to minus 2.5, that's osteoporosis. And the current guidelines say you ought to be treated for that. If you have osteopenia, so your T-score is between -1 and -2.5, and you have risk factors, I told you about that FRAX questionnaire. If your risk factor for fracture in the next 10 years greater than 20%, you ought to consider treatment. And if your hip fracture risk in the next 10 years greater than 3%, you ought to consider treatment. But I have some patients who are above that or below that who decide that they want to initiate treatment or not initiate treatment. So there is some consideration to be had in the discussions you should have with your physician as to what's right for you. We have lots of different medications available in the anti-resorptive family that's currently FDA approved. We have hormone replacement therapy, Evista, which is raloxifene. It's an estrogen receptor modulator, calcitonin nasal spray, and we have bisphosphonates you probably all know about, the alendronate, which is also called Fosamax, Residuate, which is Actonel, Ibandronate, it's Boniva. It's available as a pill as well as an IV once every 3 months, and zoledronic acid, which is reclassed. I have to think for a second. And the Denosumab, which is also called Prolia, it's a shot given twice a year. And these are all what they call anti-resorptive. They stop your body from breaking bone down further, because that's what happens usually after menopause and as we age. And then there's one, what they call anabolic agent. This is actually something that stimulates bone formation, and that's called teriparatide, or it's also called Forteo, but it is an injection you give yourself at home every day. And right now we're limited to 2 years because of some research study issues that they had at the time. We like to look at medications and say, is it FDA approved? Does it show data that shows a bone density improvement? But ultimately, bone density improvement itself is not enough. You have to show that this medication reduces fracture at both hip, spine, and other non-vertebral fractures. We like to see reductions in bone turnover, although that's not something we do practically in office. And we like to see some long-term and short-term safety data. So this is on hormone replacement therapy. I'll go through this part very quickly because you probably don't need to really know any of this data stuff. But the hormone replacement therapy, this is the effect on the bone density. In the spine, there's improvement compared to placebo. Hip, there's improvement compared to placebo. There's actually data to show that there is some reduction in vertebral fractures. But of course, we worry about breast cancer risk and clotting risk. We worry about heart disease risk, stroke risk. We worry about bleeding and spotting. Do you have to take something else to offset the effect? We worry about endometrial cancer, weight gain, a little bit. So there are potential problems with this. And not every dose works for this. For most women, you have to take a dose of something called Premarin, equivalent to about 0.625 or higher. Doses of 0.3, which is considered low dose, does not seem to protect you as well as the 0.6 or higher. Raloxifene is Evista. It also improves bone density of the spine as well as in the hip. It lowers the bone turnover markers. There are studies to show that there is reduction in fractures, in vertebral fractures, in a study called Moore study. But same issues with some of the side effects. These are women who are going through menopause, and unfortunately this medicine can increase hot flashes. Who wants that? It can cause increased risk of clots, just like estrogen. And we worry about, again, other clotting risk, but it does seem to reduce the risk of breast cancer. So I have some women who have kind of osteopenia with a relatively high risk with family history of breast cancer, who's not having hot flashes, who's interested in using something for osteoporosis. This may be an ideal choice for them. And this one does not have uterine spotting or bleeding, so that it is something that can be helpful. Calcitonin, calcitonin is one of the safest and mildest medicines we have, and it has some central analgesic effects like pain relieving properties. So my patients who have a fracture in the hospital that can't really take any medicines right now, sometimes I'll give them this as a bridge. And it does reduce there's some data say that it helps new vertebral fractures, but unfortunately in terms of hip fractures, it really didn't show any significant improvement compared to placebo. There's some nasal side effects because it's a spray you give yourself every day. Alternating noses back and forth, a runny nose, bloody nose, headaches, things like that can be seen with this medication. But what I'm trying to say is that estrogen, Evista, calcitonin, all of these help to some degree. These are bisphosphonate data. This is data on Fosamax, but the rest of the data all look similar. It helps bone density of the spine on the left. It helps the bone density of the hip. It shows a reduction in vertebral fractures. It shows hip fracture reduction. So these medicines really do work. This is on Actonel. There's improvement in bone density of the spine, improvement in bone density of the hip. There's fracture risk reduction. And this is Boniva, similar kind of data. There's reduction in new vertebral fractures in patients who have had prior vertebral fractures. And in non-vertebral fractures, there's actually shown that there's reduction in fracture reduction with that. So Actonel, Boniva, Fosamax, they all help reduce risk of fractures. But there are side effects with these medications as well. There's no free lunch with anything that we give you guys. They can cause nausea, upset stomach, esophagitis, gastritis. Some people, after they take this medicine, get a little bone achiness and bone pain. Sometimes it can last for several weeks. There's a problem called osteonecrosis of the jaw, where some people during implants or dental work may have the exposure of the bone, and you have to get off these medicines to heal it. And something that we've been more concerned about recently called atypical fractures, where if you've been on this medicine for many years, 5 years plus, you may experience increased fractures from a medicine you're trying to take for fracture prevention. So we do right now for many people limit this to 5 years, after which again you should discuss with your doctor whether this is an appropriate thing to continue or not. But it does have significant reduction in fracture. 40% for vertebral fractures for most people. The bone density do increase. We can combine this with other osteoporosis medicines. So we have used Fosamax or Actonel, Boniva with estrogen or with Evista. And sometimes the combination does give you a slightly higher improvement than one of those agents alone. And it's not hormonal, which some people are concerned about. Then we have this medicine called Denosumab. This is called Prolia. It's a shot you get in your doctor's office twice a year. It's a fully human monoclonal antibody, and it blocks something called rank ligand. And this is a protein that causes the immature cells that break bone down to mature, so that it increases that rapidity of breakdown. So this medicine will slow that down. It'll osteoclasts are the cells that do that. It'll decrease its formation and mediate its survival and make it shorter. There are some side effects that we have seen, but it's between the placebo and the drug. It's been fairly comparable, but there's a slightly higher incidence of infections, not where you get the shot, but at other places. But the importance of that is actually not really clear to me. There's significant fracture reduction with this medicine as well, in the vertebrae up to 68%, in the hips 40%, in what they call non-vertebral fractures like wrist fractures and other fractures by 20%. So it has shown good efficacy. Forteo, which is the anabolic medicine that I say was an injection that you give yourself every day, it's approved for both men and women, especially people who have failed the other agents. I will use this medicine. Or if I think that you have a problem where you're not breaking bone down but not building bone, this is a medicine that I use for that. But it is limited to, again, 2 years of usage. And after 2 years, we usually follow that with a bisphosphonate or with another medication that slows the breakdown in order to make it get a little extra bang for the buck. This shows significant improvement in bone density of the spine and also significant improvement in bone density of the hip. We have other medicines coming up, which we're quite excited about. There are what they call parathyroid analogs. There's one called abaloparatide that is on phase 3 trials. So hopefully in the next couple of years we'll have more available for you. There are different medicines of totally novel mechanisms of action. One called anti-sclerostin, and the data on that on bone density looks really tremendous. But right now we're waiting for fracture data to see how well does that do. And there's something called cathepsin K inhibitors. There are strontium renylate is used in Europe for osteoporosis, but it's not approved in the United States. It's a supplement. So there are a lot of resources available online for osteoporosis information. And National Osteoporosis Foundation and which is a local group in Oakland area, is a really good resource. And thanks to Dr. Shibuya and to Victor for hosting this event and organizing it, and for letting me borrow some of his slides. If you don't mind, I can go to the gout talk, and then we can talk about both afterwards. Is that okay? All right, so let me close this out. Gout's, again, this is another hour talk, but I'll have to fly through some part of it. Gout is a problem where when you eat certain proteins, purines, they're broken down by different enzymatic pathways into uric acid. Gout appears to be increasing in incidence over the years. When you look at it, as people age, we get more and more gout. Women after menopause have also increasing incidence of gout. And again, just even over the years from 1995 to 1996 versus 1977 to 1978, we have much higher incidence of gout. And it might partly due to our dietary patterns and what we're doing to ourselves. Same thing with osteoporosis. There are risk factors that we have for development of gout. Some which you can do something about, and some you can't do anything about. You know, being a male, unlike osteoporosis, is a risk factor for gout. As you age, your kidney function declines and your ability to get rid of uric acid declines. And for women after menopause, loss of estrogen, which actually helps you excrete uric acid more, is a risk factor for gout. If you have organ transplants, can be a problem. And in some populations, Filipino populations, Samoa populations, there's a problem with their kidneys where we see also an increased incidence of gout. If you have high uric acid, this is something that you can do something about. If you're having obesity, metabolic syndromes, this is probably the reason why we're having more incidence. High blood pressure, high cholesterol, diabetes, these are all contributing factors. So if you can modify those with weight loss and exercise, modification of your food intake, you can actually control this to some degree. Foods high in purines, meat, seafood, sardines, anchovies especially, alcohol of all kinds, especially beer, and foods with high fructose. And those are the sodas that people drink. That has been shown to contribute to gout. Medications like water pills, diuretics, hydrochlorothiazide, Lasix, furosemide that your doctor may be giving you for your high blood pressure or water retention in the legs can contribute to development of high uric acid and gout. So this is something that you may have to discuss with your doctor and say, you know, I'm having this problem. Do I really need to continue with this medicine or not? And in some cases, you may have to. And in other cases, maybe they can modify the dose or discontinue the medication altogether. Low dose aspirin can also cause elevated uric acid, although high dose aspirin does not. So it depends on what you're taking. It can affect the excretion of the uric acid in the kidneys in different ways. Niacin, tuberculosis medications, and if you have lead exposure, if you're somebody who's eating lead paint, I guess they could do it. There are some areas where there's been lead in some of the water sources, so in well waters. So we do have people watch for that. Risk factor for development of gout, again, high blood pressure, all these cardiovascular risk factors do contribute to metabolic syndromes. And this is something that you can do something about by weight loss, again, modification of diet. I have to go through this. Let's go through this. Actually, the chronic kidney disease is something that I think people should know about. Your kidneys are responsible for filtering uric acid out from your blood. And if you have kidney disease, your body cannot filter it out, and it causes increase in uric acid in your blood. And that can also contribute to high blood pressure. People think that elevated uric acid, besides causing gout, may contribute to cardiovascular disease. For men, if your waist is greater than 40 centimeters, if your triglyceride is high, if your HDL cholesterol is low, that's the good cholesterol. If your blood pressure tends to run high, or if you have impaired glucose tolerance, that's considered metabolic syndrome. And if you have that issue, again, modification of diet and lifestyles may be able to help reduce your incidence of gout. People who have gout, if you look at the left side, that's the green bars, those are the people who have gout versus people who have no gout. If you look at the people who have metabolic syndrome that we just mentioned, the people who have these people have greater incidence of gout versus people who do not have that. So let me go through this. Diet rich in meats, increased risk of gout. Seafood, alcohol intake, all increased risk of gout. There was a study from New England Journal by Dr. Choi, published many years ago, that talked about drinking skim milk or fat-free milk or on a daily basis was able to reduce the incidence of gout. So I do encourage people to do that on a regular basis. Vegetables with a higher purine content did not appear to have increased incidence of gout, but the alcohol and seafood really did. So we do think that there's a difference in different foods that you can choose with purine contents that are maybe a little bit higher. Let's see. And some people, I have had some people say, well, if I just modify my diet, is that going to correct my gout? If they have levels like 9 or 10, which is fairly high, changing the lifestyle can only reduce this by 1 to 2%. So many of our patients do need to be on some medicines to control this. Uric acid is a crystal. And actually the background that I have, this like this purple background with these little needle-like things in the background, that is actually a microscopic picture of what gout crystals look like. And normal level, I tell people if you take a glass of water and you put salt in it, at the beginning you can easily dissolve it. But as you keep putting more and more salt into that area, into the cup, you're going to see it precipitate out of solution. Do you see what I mean? So uric acid has what they call there's a solubility factor, and that level is at 6.8. When you get your blood test results and you say, oh, uric acid level normal is under 8.5 and level is a normal, that is actually a population number. So if they take 100 people off the street, they may have 100 people running numbers in that area, but that does not mean that's where you need to be. We really like uric acid levels to be below 6.8. If you have gout or any other problems, you really should be below 6. We actually I aim my patients closer to 5, and there's less chance of gout attacks if you get to that point. Most patients who have gout have problems where they're not able to get rid of the uric acid that they have in their body because their kidneys are not able to pee it out. About 10% of the patients have it so that they make too much uric acid. I have an 18-year-old in my practice who have gout, and he has a problem where he can't pee. He has overproduction of uric acid. When I measure his urine uric acid, he's got high levels. His kidneys are working as hard as he can to get it out. But that's about 10%. If I see young people with gout, that's what I'm looking at. For most of my patients, older patients who get gout as they age, it's usually because they're not excreting it well enough. So there's a metabolic pathway. So when you eat proteins, or if you're taking something that has uric acid, purines in it, it gets broken down by these enzymatic pathways that into this thing called urate, which is uric acid. And then usually that is gotten rid of our bodies 80% by our kidneys, and then about 20% through our intestine. And in other animals like birds, they have an enzyme called uricase, which as humans over the evolutionary chains, we have lost that ability to have that enzyme, so we don't make allantoin. And then once you get the uric acid, you either try to get rid of it in your kidneys, or you get it built up in your body. And if you get it built up in your body, it'll build up in your body and cause arthritis, like you can see with the gout attacks. It can maybe contributing to heart disease effects. And if you put a lot of uric acid through the kidneys, you can get kidney stones. So a lot of the things that we do are geared toward blocking this pathway. So you may hear about medicines like allopurinol and Uric. Those medicines block the xanthine oxidase here so that your body's not making as much uric acid. There are newer medicines called Crystexta, which is actually a uricase enzyme. This is given as an IV medicine that allows us to make the allantoin and get rid of the uric acid that way. We also have medicines like probenecid, and there's some newer medicines that are under investigation that are trying to find ways to get rid of it through the kidneys a little bit better. So people are really working on ways to improve gout treatment in the future. Gout crystals deposit anywhere in your body. The most common way that this presents is what they call podagra, the big toe being inflamed with a sudden onset. But you can get gout in other parts of the body, in fingers, knees, ankles, in the tendon sheath. If you have a lot of uric acid, it has to go through the kidneys. It can form kidney stones. Some people actually have so much uric acid load that it deposits under the skin and forms something called tophi. I think are we approaching time? Okay. When somebody has asymptomatic elevated uric acid, we really want people to try to do whatever they can to bring it down. Right now, they don't recommend that we treat that with medications to bring it down, but I think the future may be coming. because again, there's some evidence that elevated uric acid may translate to increased risk of heart disease. During acute flares, we use medications. Let me go through this quickly. Gout attacks can look like this. That's a podagra on the left side with swelling in the ankle. This is what they call gouty bursa. People can get tophies with development of this kind of white creamy things. This is when you look at, take the fluid out of the joint or bursa fluid, look under the microscope with something called a polarized microscope. We can see these polarizing crystals that look like needle-like in structures. Let's see. I wanted to use. Let me take that. So when people have gout, the higher the rate, the more likely you have flares. And just because you had one attack and it goes away, it does not mean you're free from this disease. The recurrence rate is actually very common, and the crystals still remain in your joint. It doesn't go away. And recurrence rate for gout is actually very high, and normal people within 3 years, more than 3/4 of the people will have another flare. And X-rays sometimes show changes of sometimes what they call overhanging edges, and it does eat your joints up. So it is not something that's going to just go away and not cause any problems. So it is a disease that we really do need to address. Sorry. If somebody's having a gout attack, we usually treat that with anti-inflammatories. Oftentimes Indocin, Naproxen, Motrin, those type of medicines are called NSAIDs. And we do that for about a week period, depending on how long the attack lasts. Sometimes we'll give people cortisone injections or even prednisone or cortisone pills to see if we can kind of get them over that acute crisis. We do use colchicine. Right now it's marketed only as Colchris. You can take it once or twice a day. Some of my patients do have diarrhea with that, but if you take it with foods, that might be helpful. Usually once the acute attack is over, I have people stop the anti-inflammatories, but the colchicine does need to be continued if you're planning on using a medicine to lower the uric acid. One of the things I like to really emphasize to people that if you have gout, do not start or stop uric acid lowering medicines at the time of the acute attack. I don't know how many times I've had people come from the emergency room, having stopped their medications, and then the doctor did not know, had them restart the medicines, and the gout flare just continues. You don't want to be starting or stopping uric acid lowering medications during time of flares. You really need to be quiet when this happens. And I think some doctors even forget that, so you need to know that, and I really emphasize this to my patients. If you're having, maybe one attack and you're not having any other problems, sometimes I do watch people over time if I can modify their lifestyles. If they're having ongoing attacks, more than 2 attacks, I actually think that they need to be treated to control this problem because it's a metabolic problem that does not go away. Your kidney functions do not improve. You do not excrete more uric acid over time as you age. So usually most of my patients do need to be on some medicines. So at the beginning when you have an attack, you take an anti-inflammatory, you take maybe colchicine. Once the attack is over, you continue the colchicine, but you stop the anti-inflammatory. After you've been on colchicine type of medicine for a while, and if you don't have any problems and nothing going on, at that time I will actually add the uric acid lowering medicine, allopurinol, Uric, probenecid, or whatever they need to be on. And I usually continue the colchicine along with the other medications for months. Sometimes 4 to 6 months. I think recent studies suggested we should be doing that for about 6 months for some of these medications. After which, if you have no attacks, then we can stop the colchicine and then continue the uric acid lowering medicine by itself. Being on this medicine alone does not mean that you're never going to get an attack. If you have indiscretions of your diet, I've seen gout attacks even with being on these medications. But the lower your uric acid level, less likely that will happen. Let's see. I think we talked about the diet already. These are some of the medicines that we have available. Probenecid, and there's also something called cobenamide that's a combination of colchicine with probenecid that actually works as well in combination if you need both. And that medicine makes you pee uric acid out. But if you have kidney stones with uric acid, or if you have impaired kidney function, this may not be the medicine for you. Allopurinol is a medicine that's been tried and true for a long time. We usually use somewhere like 100 and 300 milligram tablets. We go as high as 600 milligrams to control the uric acid level. So I do have people check the level, monitor it. There are some allergic reactions that can come from this. So at the beginning, I do watch people, and I do check the blood count and liver function test about 1 month and 3 months after starting this medicine. Febuxostat is a new medicine called Uric for people with maybe slightly worse kidney functions. Some people think it might be more potent, and data certainly shows that this may be more potent than allopurinol. If you're using allopurinol, which is very inexpensive, available as generic, and it's not able to get you to target uric acid, then Uric may be a good choice for you to try. And these medicines block the formation of uric acid at that xanthine oxidase, where I was telling you about. There are some newer medicines available. There's one called Crystexta, which is a uricase, which is that enzyme that pushes the uric acid to the allantoin pathway, and it's approved, but it's an IV that you do every 2 weeks. And there are some blood tests you may need to get checked before you start the medicine. If you have something called G6PD, you may not be able to tolerate it. And we do recommend that you not take other uric acid lowering medicines at the same time. So, please read the inserts if you're getting the brochures. But it's an IV that you do every 2 weeks. And they have to measure uric acid levels on a regular basis. There are some other medicines that are in research right now. There's one called Rilocept that we use to kind of lower the attack rate in people who are getting some of these medications. It's going to work kind of like maybe colchicine, but not. It's a different mechanism of action. And there's some other medicines that help us pee uric acid out. The goal of uric acid management is to get it, again, down to 6.0 or less, again, ideally down to 5. Again, having your uric acid level within normal range for the lab is not the goal. So anyway, I think we can talk more, but I think I'm running out of time. So I'm going to thank Dr. Shibuya and Victor Mo and open up to questions or whatever you may want to ask me. Sorry if I talk too fast.
Don't be shy. Any questions?
Do you have any questions or any concerns about anything? Yes. Hi. How are you?
Hi. I was wondering if you might talk a little bit about the holiday from osteoporosis medicine.
Right. Well, there's some controversy with that. I think most people say that after you've been taking the bisphosphonates, the Actonel, Fosamax, Boniva, Reclast, that after 5 years, the incidence of atypical hip fractures. And when you look at the hip bone, there's what they call if this is the pelvis, this is my bone here, this is the head of the femur, and that's called the neck of the femur, and this is what they call the shaft, and there's a greater trochanter. Most people, when they have osteoporosis fractures, they get it across the skinniest part of the hip called the neck. But there's some people who are developing atypical fractures, what they call subtrochanteric fractures, after they've been on this medicine for a long time. Exact mechanism of why this happens is really not clear. Some people theorize that it may be related to maybe these people, since the bone is a mechanism where you're making bone, you're breaking down bone, you're making bone, you're breaking down bone, and there's a cycle that happens. And after menopause, the problem is that people are breaking the bone down so much that you're trying to stop that, and all the medicines in this group slow down the breakdown of bone and reabsorption of bone. But there may be some people where they're osteoporotic not because they're breaking bone down, but maybe they're not forming bone enough. And if you're giving people who have not very inert bone that's not forming a lot of bone, these medicines that slow this down, that they may have an inert bone and they may be more vulnerable to fracture. So currently we recommend that after 5 years of being on a bisphosphonate that you take a holiday, or we don't like to use the word break, from these medicines to see if we can kind of offset that effect. But people are being watched to see whether, how long we have to stop for, what we do. So some of us who do osteoporosis management, when we stop the medicine, I'll check again, we have bone turnover markers. It's not used commonly, but in certain cases like that, I would check the bone turnover marker when I stop the medicine, called serum CTX and some other things, to see, because if you're on those medicines, the level would be very low. And then sometimes 3-6 months later, I may check it again to see if it's picking up. Because if the effect of the medicine is gone and there's accelerated bone turnover, then there may be some problems down the line. And I sometimes don't want to wait 2 years to find out that they've lost a lot of bone. So I will sometimes check it to see if there's a change that I can see in bone formation markers. But that's probably the only time I really check that on a regular basis. But there's debates about how long you stop for, who should be stopped and who should not be stopped. People say if you have high risk, then maybe you should not stop. But it's not clear who's defined as high risk. So there is, depending on who you talk to, there is some debate. But I think most people currently recommend after 5 years you take a holiday from it.